Hi guys, the topic that I'm going to teach you now is polycystic kidney disease of the autosomal dominant variety, which would have an adult presentation. Now, before I get into the clinical details of the disease per se, I would focus on three important points which are must know for you from the exam perspective. The first and the foremost would be that you would have humongous kidneys, grossly increased kidneys. In fact, this is what Harrison says data wise. He says the length of the kidney of this person would be almost 4 times when you're doing an ultrasound for screening of these patients or a workup of these patients. The length of the kidney can be as much as 4 times as compared to the length of a kidney of a normal person. And when it comes to the weight, look at the data that I'm writing. It looks very shocking when you read it the first time. The weight of the kidneys in ADPKD can be up to 20 times that of normal. Now, what's the importance of knowing these values is, I mean, they're not going to ask you these values, but the importance of these values is that you see, whenever kidneys will fail, then one of the strategies that we always use in end-stage renal disease is peritoneal dialysis. Obviously, we can do hemodialysis, we can plan a kidney transplantation for the patient, but you are aware of the fact that peritoneal dialysis is also a solution that can be offered to patients who are having a kidney failure. But you cannot do a peritoneal dialysis in these patients. Why? Because the entire peritoneal cavity space is occupied by this humongous grossly increased kidneys. You see, after all, you need some space where the dialysate fluid can be introduced and you can do a peritoneal dialysis of the patient. In this case, there's no space because the entire space is occupied by this grossly enlarged kidneys. Well, this condition that I'm teaching you overall is, I mean, this is what I'll again quote Harrison. He says, this is overall the most common life-threatening monogenic disorder. In multiple choice question, he could mention a couple of other autosomal dominant or monogenic disorders per se. Like he could mention Huntington's chorea, familial hypercholesterolemia, pretty debilitating disorders actually, and the neurofibromatosis, polycystic kidney disease, the topic that we're studying. And he would ask you that which of the following is overall the most common life-threatening monogenic disorder, then your answer is going to be the topic that we're studying. In Harrison, the value given is about 1.2 million people suffer from ADPKD per se. And now let's look at the genetic basis behind the development of the disease, which would be relatively easier for you to answer because I am very sure you would have read about the genes and the chromosomes involved from pathology domain as well. Well, the gene that I'm talking about in this condition is PKD1 and PKD2 gene, and they encode for two proteins. Now, where are these proteins located? That is also important for us to know, but let's just jot down for the sake of completion. The name of the proteins, that is polycystin 1 and polycystin 2 protein, they form a complex in the kidney, where in the kidney also I'll tell you. But this entire setup is related to chromosome 16 and chromosome number 4. Now, if you have a problem in any of these two chromosomes, then polycystin 1 or polycystin 2 production is compromised. I'll just use a short form now, PC1 and PC2. Whenever I'm writing, it means polycystin 1 and polycystin 2 protein, they form a complex in the kidney. Now, where is this polycystin 1 and 2 found in the kidney per se? So your answer would be that these protein complex is located in the cilia. Now, traditionally, I mean, whenever we read about cilia or when we read about cilium, I mean, that would be plural cilia. I'm just writing the word cilium. I mean, whenever we read about the word cilia, we always associate it with the lungs. But today, I'm highlighting the fact that cilia would be present even in the renal tubular cells. Why would cilium or cilia be present even in renal tubular cells is because this cilia would be like a hair-like structure. What this hair-like structure would be doing in the renal tubular cells per se would be that this will act like a mechanosensor. You see, after all, you are having a ultrafiltrate which is traveling through the tubules per se. So this PC1, PC2 complex, this is gonna function like a mechanosensor. It's gonna measure how much is the ultrafiltrate traveling through the tubules. And at the same time, it's also going to act as a chemical sensor because we would be having multiple electrolytes which are going to be lost in the urine, sodium, potassium, calcium to name a few. So this is also going to act like a chemical sensor as well. So per se, PC1, PC2 complex is present in the kidney tubules. And our kidney tubules also have these apical projections in the form of cilia, and the function of the cilia would be that they would be a mechanosensor, they would be a chemical sensor. Over and above this, I can also add that this PC1, PC2 complex is also going to regulate the calcium excretion from the body, the calcium balance in the body, and it is also responsible for G protein signaling. Now, the importance of this will become, why this data is being told to you will become obvious in few seconds from now. At the moment, I said this complex of polycystin 1 and polycystin 2 protein complex, which is found in the kidney tubules, serves four important functions. I'll name them once again: mechanosensor, chemical sensor, calcium balance in the body, and G protein signaling. Now, because of the defect of the chromosomes, because this complex will also not function properly, so all of these functions will be hampered. And because of the loss of these functions, especially the last word that I wrote, I said PC1, PC2 complex plays an important role in G protein signaling. He says that because of the defective functioning of this complex, because of the genetic reasons, the end result is that there is going to be a defective G protein signaling. And because of this defective G protein signaling, there is an increase in the value of cyclic AMP. Traditionally, we read about cyclic AMP values being increased whenever we're reading about cholera toxin contributing to a secretory diarrhea. But today I'm telling you that once the PC1 and the PC2 complex of proteins in the kidney tubules is not functioning properly, there's a defective G protein signaling contributing to increased values of cyclic AMP. Now, the importance of cyclic AMP is that it causes a development of cysts. It rather causes progression of the cyst also. The cyst could be present since childhood, but they tend to increase in size as the age of the person is increasing. So they're responsible for cell proliferation. Cyclic AMP basically helps in promoting the cyst growth of cyst growth as the individual tends to grow in age. And when I'm going to talk about the treatment part of this condition, I'm going to incorporate a drug which will be inhibiting the proliferation of the cysts. You see, after all, once the disease will occur in a person and he goes into end-stage renal disease, we'll have to go for renal replacement therapy. We will have to plan a kidney transplantation for the patient. But can we do something to rather inhibit or to rather slow down the progression of the development of cysts in polycystic kidney disease? I'll just give an example. Like in diabetic nephropathy, we use ACE inhibitors to slow down the progression of the disease. Similarly here, today I'm trying to teach you that he'll ask you what molecule is used in patients of AD-PKD who have a high chance of progression to end-stage renal disease. Then one of the molecule that we use is vaptans. This becomes concentrated in the tubules of the kidney. You very well know vaptans are used in treatment of nephrogenic diabetes insipidus. And what vaptans do is, if you get into pharmacology, what vaptans do is that they tend to inhibit those cyclic AMP pathways. And by inhibiting those cyclic AMP pathways, they are going to try and neutralize the manifestations that occur in this patient, which is development of cyst and then progression of the cyst and increase in the size of the cyst. There is some fluid inside the cyst also, which would be having a composition partly identical to that of the ultrafiltrate, because we would be having aquaporin receptors here, we would be having chloride channels here. So the fluid which is present in the cyst would be having a composition partly similar to that of the ultrafiltrate. And obviously they could also be bleeding in the cyst also, and the bleeding in the cyst could result in increase in the size of the cyst, stretching of the capsule of the cyst, and that explains the commonest clinical presentation of the disease, that is flank pain. I repeat once again, I said because of the defective proteins due to defective reasons, there is going to be upgrade of cyclic AMP which promotes cyst growth in these patients. And because we were able to document this, we have now been able to prove the fact in clinical trials that vaptans, which tend to inhibit the cyclic AMP pathways, we can retard the progression of development of the damage in the kidney, and we can actually slow down the progression to end-stage renal disease in these patients. And usually the molecule used in this condition would be answered by US tolvaptan. Now, before we go forwards, I would like to add a detail which is added in the 21st edition of Harrison, because traditionally whenever we read about this topic, we read about defective genes, that is PKD1 and PKD2, as I explained to you. But in the 21st edition of Harrison, he has mentioned two more genes on this topic, which I would like to highlight. One of the important genes which is related to this topic is GANAB, G-A-N-A-B, and the second one is DNA GB11. Now, the importance of knowing these additional genes is that these two genes, which are newly documented for autosomal dominant variety of polycystic kidney disease, he says both of them are responsible for clinical profile identical to that of ADPKD with PKD1 and PKD2, but the disease tends to be milder. In fact, he says that the size of the cysts that develops with this genetic disorder or this defective gene would be relatively smaller, and you could either be having normal size kidneys. You see, when I started this topic, I taught you that the size of the kidneys could be 4x the length, 20 times the increase in weight. And look at the shocking thing that he's saying now. He says the size of the kidneys could be normal. In fact, in some cases, there can also be reduction in the size of the kidneys. So traditionally, we were always reading ADPKD, we have humongous, grossly increased kidneys. But in these two mutations that I've explained before you at the moment, he says the fact that the kidney size could either be normal or rather could be, especially with the second one that I've written, DNA JB11 mutation, he says the size of the kidneys could also be relatively smaller. Why that is important for you is because every time you read about this term ADPKD like, there's an additional term that is written ADPKD like. Then the moment you read this word like written, which might be written in italics towards the end of autosomal dominant polycystic kidney disease, you need to remember he's talking about these mutations where the disease will be milder and the size of the kidneys would either be normal or would be smaller. The traditional information still holds true. PKD1, PKD2 gene, grossly increased kidney size. But if he says ADPKD like manifestations, then your answer is going to be these defective genes and the size of the kidney would be answered as normal to be reduced. In fact, before we go forwards, I would also like you to remember that in multiple choice questions, he might deliberately play with English and might use this word ADTKD. ADTKD would stand for autosomal dominant tubulointerstitial kidney disease. Look at the slide change here. We're not talking about polycystic kidney disease, but tubulointerstitial kidney disease. This is covered in the subsequent video ciliopathies, but the gene which is involved in this case would be called as UMOD with codes for uromodulin. So I have covered the topic of ADTKD in my subsequent video ciliopathies, but I just thought that I'll mention the term once again. There are three terms, guys, that I'm trying to tell you. Traditional data is ADPKD. Then your answer is PKD1 and PKD2 gene, polycystin 1, polycystin 2 protein. If he says ADPKD like syndrome or a disease, then your answer would be GNAB and DNA JB11. And then I mentioned ADTKD, that's tubulointerstitial kidney disease, that would be related to UMOD gene, and which codes for uromodulin. So these are like a couple of, because genetics is the in thing nowadays, and it's not possible to remember all the genes and all the chromosomes in a single day. So it's always like 1 and 2 every day. Like here I've incorporated a couple of additional genetic disorders that you should be knowing from the exam perspective. Now, coming to the clinical manifestations of the disease, I want to tell you that this autosomal dominant disorder has a complete penetrance. What I mean by the word complete penetrance is that it is expressed in every generation. But the disease would be having a variable expression, like suppose a brother and sister both are having autosomal dominant polycystic kidney disease. There is a 30-35 years of age, he might go into end stage renal disease and might be requiring a dialysis. The sister of this guy, she is also suffering from the same disease, but she may remain asymptomatic for her whole life and may never have to go and see a doctor. Or I can say vice versa, the girl, she became symptomatic, or maybe she when she was pregnant, she on her ultrasound it was found that she's suffering from polycystic kidney disease, and then she deteriorated over the next couple of years and had to undergo a kidney transplantation. And the brother was suffering from the same disease. Even on his ultrasound, multiple cysts were present, but he had never to undergo, he had forget about going to a nephrologist, he had never to undergo any other testing apart from that screening test that was done, and the boy remained asymptomatic for his entire life. So look at the term that I wrote. I said it is going to be expressed in every generation, but there is a variable expression in the disease. And apart from this variable expression, I would also like to say that in majority of cases, there can be a variable presentation as well. When I say variable presentation, a large number of cases might actually remain asymptomatic, which is that only on a workup of these patients, maybe that was done for some other reason, like the girl, like I was describing, the sister of this person who have at the time of pregnancy, when she went for an antenatal ultrasound, that is when the diagnosis of the patient will be made. On the other hand, in some cases, the presentation would be much more gross, in a sense that they could be bleeding in the cyst, stretching of the capsule of the cyst, and then development of back pain or a flank pain in the patient. In a multiple choice question, if he says what is the most common symptom, see, point number one is just to explain to you variable presentation, variable expression. But if he says overall, what is the most common presentation of this condition or most common symptom in this patient, then answer would be given as flank pain. The reason for this flank pain can be one, that there could be a cyst infection. I mean, it's not only that there could be bleeding occurring in the cyst. Yes, it could occur, but apart from the hemorrhage component, cyst infection could occurring in a person. So urosepsis is to be considered. Antibiotics have to be given in these patients. And there is also a tendency of these patients to form kidney stones. The most common type of kidney stone that we encounter is calcium oxalate. But if he says what is the commonest type of kidney stone encountered in polycystic kidney disease that don't answer calcium oxalate, then answer would be uric acid stones. Apart from the flank pain and back pain in these patients, another symptom that can be experienced is gross hematuria. But for gross hematuria to occur in these patients, the cyst should be communicating with the collecting system. You see, lots of time the cyst may not be communicating with the collecting system, so you may not have is a gross hematuria. But he says, he mentions this in italics in the book, that if the cyst ruptures and communicates, you see, it's not only a simple rupture of the cyst. He says the cyst will rupture and then this is connected with the collecting system. Only then would you be having is a hematuria manifestation. If the cyst ruptures and it's not connected to the connective system, gross hematuria manifestation cannot occur in these patients. As I explained to you, incidence of pyelonephritis, anytime there is malformed kidneys, the chances of pyelonephritis, complicated UTI in the patient would be increased, and most of the time this would be with gram-negative organisms. Then when it comes to kidney stones in these patients, nephrolithiasis, the risk would be increased. And the type of kidney stones which you will answer here is not calcium oxalate. I've already sensitized you to that. Your answer would be that the type of kidney stones found in these patients will mostly be uric acid stones. Now, because this is a disease of the kidney tubules, these patients would also be having is a defective renal acidification. And because of this, because protons cannot be excreted, therefore there would be a chances of development of metabolic acidosis in the patient. Over and above this, renal cell cancer can also develop in these patients. The incidence of development of renal cell cancer in these patients is same as other population. I mean, as compared to you and me, the chances of development of RCC in this person would also be the same. I repeat this again. Why? Because I was saying chances of UTI in these patients is higher. Stone formation in these patients is higher. Chances of ESRD development in these patients is higher as compared to you and me. Renal cell cancer risk is identical to that of normal population. But if RCC will occur in this patient, it can be bilateral or it can be multicentric. I mean, traditionally, when we read about renal cell cancer, it's going to be like on the lower pole of the kidney. And here we are having maybe both the poles of the same kidney, or maybe even sometimes it could be bilateral renal cell cancer developing in a patient. So I can say that incidence is same, but the severity with which it develops could be relatively much more. And I've already sensitized you to the fact that if he says what is the leading cause of death in these patients, then the first answer of yours would be given as cardiovascular mortality. When I say cardiovascular complications, because kidney is getting damaged, so the GFR of this patient will keep on progressively getting reduced. The reduction in the GFR of the patient will cause a positive stimulus to RAS and will contribute to high blood pressure of these patients. It will contribute to left ventricular hypertrophy. So cardiovascular complications are the leading reason for death of these patients. If suppose cardiovascular complication is not given, then the second answer of yours would be given as sepsis. I mean, I know that the tendency of most people would be, I mean, even when I was a student at your age, I mean, I used to think, kidney is getting damaged, so end-stage renal disease. Yeah, ESRD will occur in this patient. If the GFR of the person becomes less than 15 ml, normal is 125 ml per minute. When the GFR of the patient is less than 15 ml per minute, 1.73 meter square of body surface area, then the term used is end-stage renal disease. In fact, in the current edition of the book, he does not use the word ESRD, but he just says the word renal failure. I mean, when you tell somebody end-stage renal disease, It looks a very depressive diagnosis. So currently in the book, in CKD topic also, I broached on this. They use the word renal failure to describe end stage renal disease, just to, I would say, reduce the emotional impact of the diagnosis that you're making on a patient. But since we are as doctors talking about among ourselves, I just mentioned this cutoff, that this is the time when uremia manifestations would be full blown in a person. So before the person goes into this GFR value, we need to plan a kidney transplantation for these patients. I mean, the definitive treatment for these patients would be a kidney transplantation. And normally when kidney transplantation is done, the old kidneys are not removed. We let the old kidneys be wherever they are, I mean the traditional place, and the new kidney is placed in the right iliac fossa. But in this patient, there is no space. The whole of the abdominal cavity space is being occupied by the damaged kidney. So in these patients, a pre-transplant nephrectomy will be required. In fact, there's one more reason why we need to remove those kidneys, because they're painful. I mean, a lot of these patients will become addicted to even narcotic analgesics. Addiction to narcotic analgesics can be seen in these patients, because flank pain and back pain is one of the primary reasons why they come to you. So we would be in this case going in for a pre-transplant nephrectomy. We remove the old kidneys and then we deploy the new kidney in the right iliac fossa. Whereas traditionally, whenever we do a kidney transplantation, the old kidneys are never removed. So every time you read a question with saying pre-transplant nephrectomy would be done in, then the answer would be the topic that we're studying, which is the most dangerous monogenic disorder, which is being discussed at the moment. As a result of the decrease in the GFR of these patients will also develop hypertension. In fact, this is what I was trying to explain even in point number 1, when I was saying variable presentation, most patients are asymptomatic. But the same person who's asymptomatic at the moment, subsequently he might start having headache. He might start having hypertension, and when he starts having hypertension, during the workup of his hypertension, it will be found. Initially, he was asymptomatic. He is, let me say, 30 years of age. The chap is started to have daily headaches, so he thought it is because of stress in his office. But once the blood pressure values were constantly rising, when he did an ultrasound abdomen of this patient, we found that he was having a polycystic kidney disease. So a lot of these patients may initially be asymptomatic, and then they will develop a hypertension, and during the workup of hypertension, diagnosis may be made. If the question simply says what is the most common symptom experienced in this patient, then hypertension is not a symptom. No, it is a presentation. I would say hypertension per se is not a symptom. I mean, it's a diagnosis based on blood pressure values. If he says symptom, then the answer is back pain / flank pain. But when he says how does the disease present, as I said, variable presentation, like two siblings could be having the same disease. One might have to go to the doctor every 3 weeks for a dialysis, and the second sibling is playing cricket and has never to go to the doctor, in spite of the fact that he's having the same medical disorder. And that is what I meant by the word complete penetrance, but a variable expression. Now, one of the important reasons why we're discussing this topic is because these patients could be having cysts developing in the kidney, but even could be developing in the liver as well. And these liver cysts would not be lined by hepatocytes. That's a minor point, but should be remembered for MCQs. The cysts that develop in the liver of these patients would be lined by biliary endothelium. What I'm trying to explain to you in point number 9 of this discussion is extra-renal manifestations of the disease. He knows the fact that the renal profile of the disease would have been well read by you. So the question will begin by saying, what is the most common extra-renal manifestation of autosomal dominant variety of polycystic kidney disease? Then the overall most common extra-renal manifestation is what I just explained, liver cysts. Apart from this, in this condition, even person could be having pancreatic cyst, splenic cyst, and the logic I can say is that the kidney and the liver and the spleen at the time of embryonic development develop at around the same time. So if you have a defect in development in one of them, then the defect could be occurring in the adjacent organ as well. So you could be having liver and even the spleen and the pancreatic cysts in these patients. Then he will ask you what is the most common CNS manifestation of these patients. So these chaps could be having intracranial aneurysm, and in fact they could be warning headaches in a person, and subsequently they can rupture, and therefore person will develop a subarachnoid hemorrhage. What we have also documented in these patients is that not only the problem is with the development of the liver and the kidney, but apart from this, they could also be defective arterial smooth muscle. and that explains intracranial aneurysm in these patients. And well, it can rupture at any point of time. There are no clear guidelines about that. Should a asymptomatic person with polycystic kidney disease, I'm saying like the brother is having polycystic kidney disease, so in the sister also the disease could be present. We have done ultrasound in the sister, but there are no clear studies indicating that in the sister who's asymptomatic, should you do a MRA also, because a MRA can identify a intracranial aneurysm. See, if somebody is symptomatic, we'll obviously try to do a complete workup. I'll pick up cyst in the kidney, I'll work up the patient for cyst in the liver, I'll also check for whether person is having IC aneurysm or not. But the brother or sister of this person who's asymptomatic, they have been on ultrasound shown to have documented cyst in the kidney, but should we screen them for a MRA for the brain? I mean, there are no clear studies indicating this, but if a person is symptomatic, yep, in these patients, a risk of subarachnoid hemorrhage in these patients can anytime be present, and then the question will describe a throbbing headache, and most of the time, I mean, the question might say worst headache of his life, or a thunderclap headache as the description that I've given traditionally in the topic of subarachnoid hemorrhage. Over and above this, he can ask you what is the commonest cardiovascular complication of the disease. Then the answer is mitral valve prolapse, and therefore the murmur of mitral valve prolapse or mid-systolic clicks could be described, not ejection click. Ejection click is normal auscultatory finding of opening of aortic and pulmonic valve, but mid-systolic clicks and a late systolic murmur is a feature of mitral valve prolapse that can be written in this MCQ. In fact, in some MCQs, instead of writing the term intracranial aneurysm per se, he might use the word arterial. I mean, just look at the tongue twisting terminologies that they like to use in the exam. He might just use the word arterial dolichoectasia. Both ultimately imply the same, that the person would be having is a vascular malformation in the brain, and that can rupture at any point of time, causing a subarachnoid hemorrhage. Then he might say, what are the GI associations seen with ADPKD? And these patients could be having constipation, since they could be developing colonic diverticulosis, and apart from this, they would also be having his abdominal wall hernia. And in fact, that is one more reason why we cannot do a peritoneal dialysis. Remember, in the starting of the video itself, I said we do not do a peritoneal dialysis in these patients because all the space in the peritoneal cavity is taken by the kidneys itself. Now, even if you try to do a peritoneal access, you see, because the person is having an abdominal wall hernia, when you're trying to, get the catheter inside for doing a PD, it might actually damage the contents of the abdominal hernia sac, which might be even intestinal wall as well. So peritoneal dialysis is not done in these patients. One, because as I told you, the space is occupied by the kidneys, the peritoneal cavity, and second, abdominal wall hernia or hernias, multiple, could be present in these patients. 9, 10, 11, 12. Extrarenal manifestations is one of the main reasons why this topic would be asked to you. Next, we'll talk about workup of these patients. So he will say that what test can be done in these patients to identify the presence of cysts. Then we can go in for ultrasound abdomen, and he will ask you, in fact, I can put that as a question for you guys just to see whether you studied this topic in radiology, that minimum how many cysts should be present per kidney to say that it is autosomal dominant variety of polycystic kidney disease. Then your answer would be that at least minimum 2 cysts per kidney must be present in the usual age of presentation. Most cases will present by 30 to 40 years of age. So if a person is between 30 to 59 years of age, you must be able to demonstrate at least 2 or more than 2 cysts per kidney. But in case we are having a delayed presentation, then he says that minimum of at least 4 cysts per kidney should be documented in patients older than 60 years of age. The query in your mind would be, sir, what happens if a patient presents before or less than 30 years of age? Yep, then the answer would still be 2. So I want you to remember the number 24. Anything less than 60 years of age given in a question, like he says 30-year-old guy or 40-year-old guy, hypertension was present in an individual, 30-year-old guy, office going individual, he was thinking he's having office headaches, he's stressed out about his work, found out to be hypertensive, workup showed a deranged KFT, and ultrasound showed cysts in the kidney. So said minimum how many cysts? Less than 60 years of age, answer is 2, and after 60 years of age, the answer would be 4 cysts per kidney. Instead of doing an ultrasound abdomen, we can also do a CT, though obviously it will entail a bout of radiation to be given to the patient. We can also do a MRI in the patient. So the sensitivity of a CT or MRI will obviously be high. But at the same time, there will always be a risk of contrast-induced nephropathy due to renal insufficiency. So I'll just say like this, that CT or MRI is more sensitive. But apart from this, there is always a risk of allergy with the contrast per se. So you need to, do proper documentation, be ready with the emergency kit if there's an allergic reaction occurring after administration of a contrast. And at the same time, I said, if a person is already having or his GFR is very low, then contrast induced nephropathy risk is obviously present with renal insufficiency. So checking out the KFT of the patient, calculating the estimated GFR of the patient is all the way important. Along with this, because kidneys are involved, even electrolytes have to be checked. You will notice hyperkalemia to be present as the GFR of the person will reduce. One of the very important tests that is nowadays being used for the diagnosis of this condition would be genetic testing. To test your genetics, he will say what test or what genetic testing can be offered to patients of polycystic kidney disease for confirmation. I mean, you would be doing is a mutational analysis after all. You need to demonstrate that okay, it is PKD1 or PKD2 gene which is responsible. Or I talked about the newer genes as well. So your answer would be that the genetic testing that I'll do for mutational analysis would be next generation sequencing. Just remember the name here. Next generation sequencing would be done to determine which gene has been responsible for development of autosomal dominant variety of polycystic kidney disease. And in case, you are having family history positive and ultrasound is showing multiple cysts, then the diagnosis will become easy. So most of the time in multiple choice question, he will deliberately not talk about the positive family history component. If he himself says that the person's brother or sister undergoes dialysis multiple times, 3 times per week, or the person was initially diagnosed with hypertension, then progressed to end-stage renal disease, and his CT also shows cysts in the liver, then he's giving you clues that he's talking about ADPKD. So most of the time, family history will not be given in the question, and it would be mainly the number of the cysts and the clinical profile that I explained before you, including the extrarenal manifestations, which have to be remembered so that you can crack the question. Because once he says family history, things becomes easier. Just like Wilson disease MCQ, in Wilson disease, if he says the elder brother sister developed neurological features, died because of liver failure, then you know that hepatolenticular degeneration is Wilson disease. Same here for polycystic kidney disease. So most of the MCQs, that traditional family history positive information would not be given. We'll now focus on the treatment for these patients. The first and the foremost to retard the progression or development of cyst would be a control of hypertension. He says that unless and until you go ahead with aggressive blood pressure control in these patients with use of ACE inhibitors or angiotensin receptor blockers, obviously you would not combine the two ways together because of risk of hyperkalemia. But there's a name of a clinical trial which is given. So I would just like to share with you, though in their actual exam, they're not going to ask you the name of the trial. The trial was by the name of HALT PKD trial, and this is documented that in case you are gonna do a good blood pressure control, the target which is described in the 21st edition of Harrison, the latest edition of Harrison, is same as that in the older ones like the 19th and the 20th one, that is less than 140/90. Why I mentioned this target value is because in diabetic nephropathy, the target that I have taught you or will be teaching you in case you want to listen to the subsequent videos, not in the sequence, like in endocrine component, I've also covered it. The target in diabetic nephropathy is 130/80. But for polycystic kidney disease, he has mentioned a target of 140/90 millimeter of mercury, and he said that aggressive blood pressure control with values less than this will retard the progression of development of cysts as well. There are a couple of other drugs which are also used to retard the progression of cysts that I'll explain to you. But before that, we need to handle the urosepsis component of these patients, because these patients can develop pyelonephritis. So you need to give antibiotics which can reach the cysts per se. So lipid soluble antibiotics are to be given. Well, which are those? Your answer would be Septran, that is trimethoprim sulfamethoxazole, or we can be using quinolones in the patient, so that we are able to take care of the urosepsis and the pyelonephritis component. Flank pain, abdominal pain is one of the main reasons why these patients would be coming to you. So you would be using analgesics. Now, a couple of these patients might be even, I mean, non-narcotics would anyway be the traditional ones, but in majority of these patients, there is a possibility that traditional painkillers will not work, and you will have to prescribe narcotic analgesics to these patients. And lots of time, these patients then, without your prescription, might be buying it from a chemist and might develop an addiction to the narcotic analgesics as well. For example, tramadol is one common drug that would be used by these patients to get relief from the flank pain component, because of which he has also talked about transcutaneous electrical nerve stimulation. Now, because I mean, this discussion is main about kidney and not about how to manage pain, so I've just mentioned about 10%. 10, the concept is transcutaneous electrical nerve stimulation, is that the device that provides the stimulation, that stimulation will override the pain. I mean, the pain will also be carried by the spinal cord, but the electrical stimulation provided by the device that we put overrides the pain sensation, and therefore there is a relief or a general improvement in the condition of the patient. Now, for these patients, we need to plan a kidney transplantation because they will progress to end-stage renal disease after all. But traditionally, in kidney transplantation, we don't remove the old kidneys. The old kidneys are kept in place. In this particular case, however, because the kidneys are painful and they are on a occupy entire space, so you would not be able to get space to put the new graft. I mean, imagine you have the graft ready and you can't put it because there is no space. So we do a pre-transplant nephrectomy in these patients to accommodate the allograft in this patient, and this will help in elevating the pain component in these patients as well. Apart from this, there are a couple of drugs which have been used aggressively in these patients, especially if you have a high chance of progression, like female patients with multiple pregnancies. I mean, you don't need to remember that, but just generally, I'm telling you, female patients with multiple pregnancies and they're having polycystic kidney disease, they tend to deteriorate faster. So, in patients who are going to have a higher chances of deterioration, we tend to use Vaptans. The Vaptans would be acting by decreasing or inhibiting the cyclic AMP production, and cyclic AMP was one of the villains, one of the signaling pathways. A G protein coupled receptor was ultimately causing increased values of CAB and was causing a proliferation and increase in the size of the cysts. Apart from this, we have also used mTOR inhibitors, that is mammalian target of rapamycin inhibitors, mTOR, that is sirolimus and everolimus in these patients as well. Well, what sirolimus also does is that it tends to inhibit the target cell. I mean, I'm talking about renal tubular cell at the moment. It will proliferate in an abnormal fashion, forming cysts in the kidney. So we're trying to put the brakes on those renal tubular cells which are showing an abnormal development, and thereby sirolimus and everolimus have also been used in these patients. In fact, what I say next, I have spoken about this drug, long-acting form of octreotide, that is lanreotide, for example. This molecule has been discussed to shrink the pituitary tumor in case of acromegaly. I mean, traditionally, whenever we read acromegaly, we read about octreotide, long-acting format, depot preparations. But today I'm telling you that octreotide has also been used in these patients to inhibit the target cell proliferation and thereby reduce the progression. So point number 5, 6, 7 is new approach which is being used to slow down the progression. In fact, the question's language would be, which drugs have been shown to slow the progression? Obviously, ACE inhibitors are gonna be used, but then he's not gonna be interested in getting an answer as a ACE inhibitor. Because that's common information, and that would also be easily guessed by you, because in diabetic nephropathy also we use ACE inhibitors. So he will ask you about 5, 6, 7. He will say what drugs are used to slow the progression towards end-stage renal disease in a patient of autosomal polycystic kidney disease. Your answer would be Vaptans, then would be mTOR inhibitors like sirolimus, and then would be octreotide, the long-acting format, which can be used in these patients. And in fact, in this topic, the most important aspect would be the extrarenal manifestations and controlling the progression of the disease, because ultimately in all of these patients, once the pre-transplant nephrectomy has been done, the definitive treatment for these patients would be allogenic kidney transplantation. Now in the exam, what he's going to do is he's going to mix this up with information of autosomal recessive variety of polycystic kidney disease, that is ARPKD. So let us now compare the features of ARPKD, which are in stark contrast to that of ADPKD. And the first point you need to remember for the autosomal recessive variety of polycystic kidney disease, which has a pediatric presentation, is the name of the gene. Earlier we were talking about PKD1, PKD2, easier names. Now it is PKHD1 gene, and this would be sitting on chromosome number 6. Now, this gene encodes for which protein? Like earlier, the proteins we were talking about were polycystin 1 and polycystin 2. This time, the name of the protein to be remembered is fibrocystin and polydactin complex. And where exactly in the kidney is this protein located? Then this protein complex is present in the cilia of the cells of the collecting duct. You see, to make it sound sophisticated in MCQ, you know from physiology that collecting duct would be having a medullary part of collecting duct and the cortical part of the collecting duct. So that's what I'm trying to write here, that the cilia of the cortical as well as the medullary part of the collecting duct are gonna be involved in this condition. Let's just revise this information. I said if there's a defect on chromosome number 6, this gene is malfunctioning. Because of the defect of this gene, this protein complex which has been shown, fibrocystin polydactin complex, is not working well, and well, that results in development of cysts with respect to the cortical and the medullary part of the collecting duct. In the AD, autosomal dominant variety of polycystic kidney disease, the whole of the tubule will be having a malformation and the cyst would be found. Here only a segment of the tubule is involved, that is the collecting duct per se. And now let's look at the clinical manifestations that would be occurring in these patients. And I'll be first describing to you in the clinical features the classical variety of autosomal recessive polycystic kidney disease. You see, whenever we do a level 2 scan in a pregnant lady, we do it to pick up congenital malformations. Like we can rule out neural tube defects or tetralogy of Fallot. I mean, congenital malformations can be ruled out. In this case, we are going to encounter when the ultrasound, I mean, most of the time he says in the classical variety, in utero diagnosis can be made. Now the baby is inside the mother. What he means by in utero diagnosis is that on the ultrasound, a specific finding would be coming that would alert the obstetrician and obviously you as a physician to the fact that the child is having autosomal recessive variety of polycystic kidney disease. So he will say echogenic kidneys. I mean, the MCQ will say, or the report will say that the fetal sonologist has reported that the fetus is having echogenic kidneys which are enlarged in size. These kidneys would not be functioning properly, so the amount of urine produced by the fetus would be less. You know that amniotic fluid, a chunk of it, a large chunk of it is formed from fetal urine, and if the baby will be having a malformed kidney, then the urine production of the fetus would be less, and this explains the fact that why the ultrasound report of this pregnant lady will not only say that the fetus has echogenic kidneys with echogenic enlarged kidneys, but this lady will also be having lesser amount of amniotic fluid, that is oligohydramnios. When these babies are born, they are also found to have a concomitant lung malformation. These children are simultaneously found to have a pulmonary hypoplasia, and as a result of it, in the classical variety of ARPKD, most of the time if he says what is the reason for death, like I was teaching you, the leading cause of death in autosomal dominant is cardiovascular complications followed by infection. Similarly here, though the kidneys are failing, don't answer renal failure in the ARPKD variety. Your answer would be that it is respiratory insufficiency, which is one of the important reasons for development of death in these patients. I repeat once again, in autosomal dominant variety, don't answer renal failure. It is hypertension related complications. In the AR variety, it is shockingly a respiratory insufficiency, which is to be answered. And in fact, I mean, that would be the classical presentation. And in sometimes the diagnosis might be made in the late neonatal group. If the diagnosis of this patient is made, let me say, in the late neonatal, I can say after 1 or 2 months of age, then most of the time the death of the patient would again occur because of hypertension. Yes, guys, even in pediatric age group, one is the classical presentation, baby will become or symptomatic immediately after birth with respect to pulmonary hypoplasia, develop a respiratory insufficiency and die. In some cases, the presentation might be seen after 4 weeks. And then if he says what is the leading reason of death in a later presentation, then the answer is still not to be given as end-stage renal disease or uremia or complications of uremia. Your answer would be hypertension. If it is not in the options, then subsequently the baby will anyway suffer from end-stage renal disease and would die. Now, the reason why we're studying this topic, I mean, the most important reason why we're studying this topic is because of the extra renal manifestation that is encountered in autosomal recessive variety of polycystic kidney disease, these patients would also be having is a liver involvement. But what is the liver involvement in this patient? Then do not answer liver cyst. Rather, your answer is that these patients would be having is a congenital hepatic fibrosis. And because of this hepatic fibrosis, what I can say, these kids are going to develop subsequently. I mean, if they survive, they can develop portal hypertension. Apart from congenital hepatic fibrosis, another extrarenal manifestation again found in the liver of these patients can be dilatation of the intrahepatic biliary ducts. Well, at the moment I'm talking about Todlani's classification, right? I'm gonna talk about Caroli's disease at the moment, because we are talking about in this case that the person is not only having congenital hepatic fibrosis, but along with this we also have is a development of dilatation of the intrahepatic ducts in the liver. Because of the intrahepatic duct dilatation, a simultaneous manifestation which is present in these patients is called as Caroli's disease, which is one of the varieties of, I mean, you study about choledochal cyst in surgery and you study about Todlani's classification. So I'm talking about type 5 variety here, that would be called as Caroli's disease. And the complication that would be encountered in these patients because of this congenital hepatic fibrosis would be development of portal hypertension. In fact, the arrow that I can draw for portal hypertension would be, because that would be mainly ascribed to that of congenital hepatic fibrosis. And therefore, even if these patients survive, then variceal bleed can occur. One of the main reasons why this topic is being discussed is that he would like to compare the liver manifestation of polycystic kidney disease, autosomal dominant versus that of the recessive variety. For autosomal dominant variety, you just need to answer liver cysts, which are going to be lined by, I have highlighted the statement. I'll just bring that to your notice once again, that the liver cyst would be lined by biliary endothelium. Similarly, if he talks about what's going to be the liver manifestation in these patients, answer is congenital hepatic fibrosis. Even in this variety, we can do ultrasound, or in children, we usually avoid doing a CT. So either an ultrasound or an MRI can be done in this patient. And main management of this condition would also be blood pressure control. I'm not writing it because there is no definitive drug treatment for this condition. I mean, it's blood pressure control, dialysis, then subsequently a kidney transplantation, and even requirement of liver transplantation. I mean, look at the amount of disability that you are not only having a requirement of kidney transplantation, but we are trying to do a kidney as well as a liver transplantation in these patients, because ultimately these patients would develop is a end stage liver disease. So these are the technical details that I would like you to remember for the polycystic kidney disease variety, the autosomal recessive and the autosomal dominant ones.